Good morning, and thank you so much for the introduction, Wynn, and a huge thank you to the conference organizers for the invitation to be here. This is my first trip ever to Bangkok, and it's been a welcome refuge from the snow in Colorado. As Wynn mentioned, I'm going to talk about incorporating frailty and physical function in research and clinical care. I changed this a little bit from what might be in your program, which was management of frailty, in part because I want to emphasize and encourage you all to think about including these measures in your practice or in the research that you do, as I think that is going to offer more insight into how we can actually manage frailty uniquely in people with HIV. So I want to start today by delving a little bit more into what we mean by the terms physical function and frailty. Physical functioning can span a wide variety of different abilities, from simple things like activities of daily living, how someone can feed themselves, whether they can bathe themselves, and then much higher levels of function, how someone might perform on an intense treadmill test, or how quickly they may walk on a brisk walking speed test. We can assess physical function using a variety of different assessments that can be either objective and measured or subjective and self-reported, and hundreds of different assessments have been tried and tested through the years. Some of the more common ones that we see are self-reported measures such as activities of daily living, if someone can bathe themselves, feed themselves, move themselves from the bed, independent activities of daily living, if someone can manage their finances, self-reported measures of how they feel, different gait speed assessments from a short 4-meter walk to a longer 400-meter walk, or the time to complete a 6-minute walk, some combined batteries like the short physical performance battery that looks at gait speed, time to rise from a chair, and balance testing, or things that mimic your function in daily life. So a timed up and go where someone may stand up from a chair, walk across the room, turn around, and come back again. And we can define impairment on all these different tests in different ways. Some of these are a scale going from 0 to 5 or 0 to 12, like the short physical performance battery. Some have specific cut points, like on gait speed, where we might use a gait speed cut point of 1 meter per second. Slower than that might be considered slow or impaired. Or some might have a continuous measure where we look at the time to complete 400 meters that could range anywhere from 2 minutes to 20 minutes. Frailty, in contrast to physical function, encompasses a little bit of a different idea, and this is more of this sense of vulnerability. How vulnerable is somebody to stressors that they might encounter? So looking at this figure, you can see function going from worst to better at the top of the figure. And then someone who's pre-frail or has some kind of early frailty is at a high level of function. They encounter some sort of stressor, maybe they're hospitalized or they have an infection, they have an acute drop in their function, but then they bounce back and continue at this normal level of function for many years or for many months. In contrast, someone who's frail and starts at a lower level of function, encounters that same stressor, has an abrupt decline in their function, and then slowly goes back up to where they were, but not quite getting there. And each stressor that they encounter, they continue to decline over time. If you look up frailty, there's probably hundreds of different definitions of how we can define this as well, but there's 2 main definitions that we tend to see used most frequently, especially in people with HIV. One is the freed frailty phenotype, and this really reflects that vulnerability as a physical manifestation. Can you look at someone and say that person looks frail? And this can include things like slow gait, weak grip, low activity, fatigue, and weight loss are the 5 criteria that are most commonly included here. This assessment takes about 10 to 15 minutes to complete, and it's usually done prospectively so that we can assess someone's gait speed in real time, someone's grip strength in real time. Some recent groups have tried to go back and look at some reports of questions if someone reports that they have walking impairment and come up with varieties of this, but generally it's done prospectively. And then it's scored from 0 to 5 with no impairment being non-frail, 1 or 2 impairments being pre-frail, and 3 or more being frail. The other common way of looking at frailty is by the frailty index or the Rockwood index. This reflects more of an accumulation of deficits. So the more things that someone has wrong, the more likely that they're frail. We look at variables that increase with age and are associated with health status, and this could include anything from obesity, metabolic associated fatty liver, all sorts of different comorbidities, cardiovascular disease. We look at the number of things that someone has wrong over the number of things that we assessed and come up with an index ranging from 0 to 1. This can usually be derived from chart review, so something we can do retrospectively. However, you develop a frailty index for your cohort. So this frailty index that I look at in my cohort may be much different than a frailty index that you look at in your cohort, but this number that comes out of it still seems to be predictive of mortality regardless of the group that we look at. So why do we think about frailty and functional impairments in HIV? This figure shows something that we call the pillars of aging or the hallmarks of aging, and it looks at multiple different factors that underlie most aging processes. We see environmental factors contributing to aging, declines in metabolism, inflammation, epigenetic dysregulation, stem cell exhaustion or senescence, and many of these factors that underlie aging are also the same factors that underlie the frailty process or the development of frailty. And many of these exact same processes have been linked to frailty in people with HIV, just to show a sampling of recent publications linking some of these aging pillars with frailty in people with HIV. Not surprisingly, we see that frailty occurs earlier and more frequently in people with HIV. This is data from the AIDS HIV study in Amsterdam and looks at people with HIV and people without HIV. Those without HIV are shown in the left pair of bars and those with HIV in the right pair of bars. And you can see that the percentage of people with HIV that had either pre-frailty or frailty are consistently greater in those with HIV compared to those without HIV. Highlighted in that yellow bar, about 40% of people without HIV have pre-frailty or frailty compared to about 60% of people with HIV who have pre-frailty or frailty in the 50 to 55-year-old age group. We similarly see declines in physical function that occur at a faster rate in people with HIV. This is data from the multi-center AIDS cohort study of men with and without HIV in the US, and you can see a faster decline in measures of gait speed and grip strength in those with HIV shown in the red line compared to those without HIV shown in the blue line, with increasing age that really seems to separate and start to accelerate at about age 50 or 60. So why should we care about frailty or physical function? Why should you include this in your patients? Well, frailty and physical function have been strongly linked to mortality. This is data from a cohort of older adults with or without HIV that looks at the association between gait speed and mortality. If you take, for example, these two red arrows, the top arrow shows someone who is age 70 and has a fast gait speed of 1.6 meters per second. That person's expected to have about 30 years of life remaining. In contrast, someone who's 70 and has a slow gait speed at 0.2 meters per second only has about 10 years of life left. When I show this to patients with HIV, they're struck by how much just that walking speed can really inform their mortality and their chance or their survival. Gait speed, as well as other measures of function, are major predictors of living independently with increasing age. We've shown both in people with and without HIV an association with falls and fractures, as well as an association with an increased risk of some comorbidities such as cardiovascular disease and diabetes. So with that in mind, hopefully you're convinced that you'd like to include some measure in your study or in your clinic setting. So how can you think about which measures to include and what might you think about? So number one, we should think about intervention, or you can think about including function when you're looking at interventions that could change frailty or physical function or the trajectory of frailty or physical function. So for example, you might include frailty or physical function as a primary outcome for some sort of intervention that you're testing. We recently completed a study called Exercise for Healthy Aging, where we enrolled older adults with and without HIV who were sedentary, and randomized them to either a high or a moderate intensity of exercise for 6 months. And for this study, we were really focused on how either a high or a moderate intensity of exercise might impact physical function. And so physical function was our primary outcome. We included a wide battery of different physical function assessments as we wanted to see if our exercise intervention was going to impact endurance, if it's going to impact strength, if it's going to impact how someone could move across the room. And as you can see, we saw significant improvements in almost all of our functional markers, except for one that people like to use a lot in studies, which is grip strength. And so this made us think there's something about, people were using resistance weights, they were doing lots of different weights in the gym, but they had no improvement in their grip strength. Because we included this wide battery, we had bench press, leg press, and other more intensive resistance exercises where we saw marked improvements, 27% improvement in some of these markers. And so having that battery of different assessments can give us information on how our intervention's really impacting these functional measures. We've also included these as secondary outcomes in a study. So we heard yesterday about the slim liver study, which was looking at metabolic dysfunction associated steatotic liver disease and using semaglutide in people with HIV. And someone asked a question about what happens to muscle mass. We were really interested in what would happen with muscle mass in the slim liver study, as well as what happens to physical function. And so we had included a measure of physical function in this study. And we were able to show that despite losing about 10% of muscle, we actually had improvements in physical function throughout the course of the study. So it was really helpful to have included this as a measure to give some context to what's happening to those muscle changes. I put in a caveat that sometimes regulatory agencies may require different approvals, so certainly if you are using this as an approval for a drug, you'd want to talk to the regulatory agency to make sure that they're on board with that. Example of a different secondary outcome, certainly one concern with statins is the impact on muscle. And we had a sub-study of the REPRIEVE study where we included physical function measures and objective physical function measures to see what the impact of pitavastatin would be on physical function. As you can see by the overlapping dots with the overlapping confidence intervals, we saw no impact of pitavastatin on changes in physical function over time, adding secondary data to the REPRIEVE study supporting the safety of statins in this population. So another way that we can include physical function is by looking at whether frailty or function modify the effect of an intervention. So is someone who's frail more or less likely to respond to an intervention? Statins have been a particular interest in this area. So should we be giving statins to an older adult who's frail, who has multiple comorbidities? Are they also likely to benefit from this intervention? Or anti-inflammatory agents, such as targeting these inflammatory pathways in people with HIV? Are people that are more or less inflamed as likely to benefit from these agents? We looked at whether statins or whether frailty impacted the efficacy or the benefit of statins in people with HIV in the REPRIEVE study, and we'll be presenting some of that data as an oral abstract at CROI in a couple of months for those of you that are there. And this has also been looked at in other cohorts. A large veteran cohort in the US looked at the impact of statins in older, frail adults and found that the benefit was similar regardless of frailty status. So we can think about who we're choosing for populations based on their underlying frailty. And then lastly, we can look at whether we can improve outcomes in people who are frail. So there's a lot of interest in the surgical literature on using prehab for frail patients. If someone's undergoing surgery, can they do some sort of rehabilitation before doing their surgery to improve their function and therefore improve their outcomes? There's also interest in using frailty in the cancer world. If someone comes in and they're frail and about to undergo chemotherapy, can we choose a less toxic therapy based on whether they're frail, similar outcomes but better quality of life after therapy? And something that I think is definitely a gap in the literature is whether or not we should think about different antiretroviral therapy in frail individuals or different dosing of antiretroviral therapy. Something that we might think about with long-acting injectables is whether someone who's frail would have the same pharmacokinetics with these agents when they have a lot less muscle mass. So now that you've thought about including one of these measures in your clinical study or your clinical practice, how do you choose the physical function assessment tool or the frailty tool that you might use? Well, the first thing you might think about is the prevalence of that in your population. So if you chose to look at frailty, frailty is something we hear a lot in the HIV literature, but if you dig into the different studies, it's actually pretty uncommon in many of our younger populations. In several of these first studies that I have listed on the table, the mean age is about 50 or 52, and you can see the prevalence of frailty in these populations is only about 5 or 6%. And so if you're trying to intervene on frailty, you're going to have to enroll a lot of people before you can identify your group of participants that have frailty. Certainly, we see some slightly higher rates in populations or studies that are just including older adults or individuals not on antiretroviral therapy. An example of this is within the sub-study of REPRIEVE that I mentioned, the PREPARE study. We looked at the short physical performance battery score as well as frailty. And we found that about 37% of our participants had at least some level of impairment by the short physical performance battery score of 10 or less, as shown by that bracket. However, when we looked at the percent of individuals in this study that were frail, it was only about 5%, and that's shown in those red bars at the top of these. So frailty in this population was very uncommon, but some other physical function impairments were much more common. Another thing we can think about is how responsive something is to therapeutic interventions. Does it have a ceiling effect or a floor effect, and can we actually change it? Example of this is, again, using the short physical performance battery in the exercise study that I mentioned. Our individuals that enrolled at baseline, about 60% actually had what we would consider a perfect score on the short physical performance battery, and therefore really had no room for improvement. You can see that the group that did have impairments improved over time, but we didn't have a lot of room to really have improvement in the 60% of people who had a normal score at baseline. In contrast, if we can include continuous measures that don't have ceiling or floor effects, like a chair rise time, we had people who had very high chair or fast ability to rise from a chair and people who had very slow ability, and therefore we could see an effect over the entire population. So thinking about the range of values that are in your population as well as in your assessment tool. And then there's always a question of, should we include subjective or objective markers or both? Participant-reported markers can tell us a little bit more about what people actually do in real practice. So when they're in their own environment, when they have had a poor night's sleep, or they're encountering all of their normal stressors, how do they behave versus what are they doing under close observation in your lab? Certainly these two measures, objective and subjective measures, tend to be moderately correlated with each other, but there's a lot of external influences, cultural aspects that may fit into how we interpret these. And someone may just have a bad day and report that they are doing horribly on their self-reported or their subjective assessments, which can really mess up your study outcome. I think some of these assessments can be a little bit less sensitive to change as well. If someone has underlying depression, they may report that their quality of life is low, but it may have nothing to do with your intervention. Just to share an example of the cultural influences on this, within the REPRIEVE study, we looked at self-reported physical function by a score called the DAISY score. It's a very US-based score, and it asks a lot of questions that are very US and European-centric. And we noticed marked differences between the function in our REPRIEVE participants from Southeast and East Asia and in South Asia. And these bars, the height of these bars indicate those that had a positive response on different scores, meaning that they had higher level of function. And you can see our participants from South Asia on a lot of the final questions had very low scores. So we looked at a few of these questions, and I put the examples there. Just the last two, number 11 and 12, asked about things like golf, bowling, dancing, throwing a baseball or a football. And when we thought about this, we don't know if these participants actually are impaired or they just don't have access to these activities. So I think there's a lot of cultural influences that go into how we use subjective questions and to make sure we have subjective questions that are appropriate for the population. And then the other thing we can think about is the mechanism of action. So what do we expect our intervention to do? Do we expect it to work on cardiovascular endurance? Do we expect it to work directly on the muscle or how someone's balancing, or to impact their general vulnerability as we might with frailty? Just a couple examples of how we might think of this. I mentioned this limb-liver study and that we had looked at different measures of physical function within this semaglutide study for MASLD. And we were particularly interested in how semaglutide would impact the overall weight. So we thought that that might be a good measure of gait speed or how someone might rise up from a chair because they weigh less. We also were interested in what's happening in the actual muscle. And so if we can decrease fat in other ectopic tissues, can we decrease fat within the muscle, improve the contraction of the muscle, and therefore improve strength? And so we ended up including a couple of measures of function, both looking at muscle strength as well as at gait speed and time to get up from a chair. We were also interested in, there's another ACTG study called A5383 that is looking at letermovir, which is an anti-cytomegalovirus drug for people with HIV who have low CD4 count responses. And we were really interested in how letermovir, if we can target CMV, can that also improve overall vulnerability and physical function? And so we included both frailty in this study, as well as some other measures of physical function. And this has been submitted for a late breaker at CROI. So we'll hopefully find out if that's accepted soon. And then lastly, we always have to think about logistics. So what can you do in your clinic? What do you have time for? What do you have equipment space for? What can happen in the setting that you've dedicated to do this physical function assessment? I mentioned the frailty phenotype is looking at vulnerability, but it's time consuming. It can take anywhere from 10 to 15 minutes. You need a dynamometer to assess muscle strength, which has to be calibrated regularly. Sometimes those go missing or participants accidentally walk out with them. And so definitely some equipment considerations. Other tests like the short physical performance battery is a little bit faster, but it also is somewhat time consuming. 4-meter walk or the time to rise from a chair, on the other hand, really take less than a minute or two and require minimal space or equipment. So we've talked a lot about how to think about these tests in the study or in a clinical study, but how do you actually think about implementing these in clinic? There are certainly additional limitations in clinic where clinicians are very busy, and what do you actually have time to include in clinic? I just mentioned that the frailty phenotype is very useful for thinking about vulnerability, but I think very few people actually have 15 or 20 minutes to think about including this in the clinical setting. A recent meta-analysis compared different types of frailty assessments on the time and the feasibility and kind of gave them a thumbs up or a thumbs down of what might be assessed in clinic. And you can see from this picture that they gave 3 thumbs up to something called the clinical frailty scale. And this is sort of an eyeball test. So a clinician looks at a patient and decides how frail they are just based on their appearance. And you can see this scale ranging from 1, which is very fit, down to 9, which is terminally ill. Certainly some subjectivity that goes into this, but it has been actually very well correlated with the frailty phenotype and can be something that's easily assessed and might be more feasible for implementing in the clinical setting. We are particularly interested in gait speed. Gait speed, as I mentioned, requires very little time, and it's simple to do and highly associated with mortality and poor outcomes. And we've been working and trying to get, in a pilot study in our clinic, gait speed measured as a routine vital sign in all of our patients with HIV that are 50 or older that are coming in for routine assessments. Currently, we're on a stopwatch system, but we're trying to get this sensor device installed that our seniors clinic has. Basically, there's a sensor at one end of the hallway and a sensor at the other end of the hallway, and the medical assistant can just hit the device on the wall. The participant or the patient walks down the hallway, they hit the other end, and then their gait speed pops up. On average, it takes about 13 seconds to actually hit the buttons and record the value in clinic, which is much more feasible than 20 minutes to do a frailty assessment. So we're supposed to have this installed in our clinic relatively soon, but in the meantime, we've just been doing a stopwatch measure of gait speed, and it inputs with our vital signs and our medical records. You can see an example of what a participant, one of my patients from last week, actually had for his gait speed measure when he came into clinic. So I can use this measure in different ways that I'll talk about in just a minute. So how do we use these tests in clinic? I think there's a few different ways we can think about frailty and physical function impairments if we do check these in clinic. The number one thing would be to manage frailty or mobility impairments. This can be a lot of lifestyle management things that we talked about in the afternoon sessions yesterday. Identify nutritional needs, certainly if someone's losing muscle mass, an emphasis on protein, making sure they're getting enough calories is important. Exercise is probably one of the first line things for frailty across the frailty spectrum, just like we heard with BMI in yesterday's session. Physical therapy or occupational therapy are incredibly important as other tools to help modify frailty and functional impairment. And then thinking about different comorbidities and how we're managing them. If we have a frail patient, then trying to push that hemoglobin A1C down to 6 is probably not as useful, but trying to really manage those comorbidities at a younger stage or at earlier stage so that that frailty isn't progressing with poorly controlled diabetes. We can also identify people who come in who have a rapid decline in gait speed. Our seniors clinic has been including this gait speed measure and have identified some patients with early heart failure just because they had a really fast decline in their gait speed over a few different clinic visits. When they start asking the patient more about why their gait speed might be declining, they've diagnosed new onset heart failure or other conditions. Frailty or physical function can help us think about how we're caring for our patients in general. So do they have an advanced care plan? How aggressive do they want to be with their care at the end of their life? Are they an appropriate candidate for a referral to a geriatric clinic? And maybe that frail patient should come into clinic every 2 months instead of every 6 months or a little bit more frequently. We can also think about our treatment decisions for other comorbidities. So does this patient still need to have cancer screening if they're frail and only have a few years of life left? And should this impact our antiretroviral therapy? Certainly some antiretroviral therapy like efavirenz, we would certainly want to avoid in a frail patient who has underlying risks and doesn't need additional cognitive stressors. So in summary, physical function or frailty can serve as an easy and clinically relevant biomarker of aging among people with HIV. I feel that we should include function and frailty in our clinical trials as well as in the clinical practice, and physical function and frailty can help us deliver effective patient-centered care for older adults aging with HIV. Just to acknowledge our study participants who have participated in many of these different studies that I've cited, our community of people living with HIV and aging with HIV for continuing to vocalize these physical function complications as priorities, the NIH for funding, and then several cohorts that I work with, the ACTG and the MaxWise combined cohort study. Thank you for your time, and I think I saved some time for questions.